Good afternoon, everybody. Today, I'm going to share with you the day one updates of APICON Jaipur 2022. I'm Dr. Ajoy Tiwari, and I'm the Secretary of UPRSTI. So I'll be briefly moving with the day one updates and what are the interesting things which are happening here at APICON 2022. So a very interesting topic was taken up on the very first day, and it was regarding the daily salt intake and cardiovascular diseases. So this is something which is very pertinent in our current times because we are having a very second surge of salt intake the world over, and this is because of the high intake of high salted, preserved, and processed fast foods and beverages. And most adult populations across the world have a mean sodium intake well in excess of 100 millimole per day, that is around 5.84 gram of salt. And in many Asian countries like India, it is in excess of 200 millimoles per day, that is 11.68 grams per day. According to a statement by Director General of WHO on 5th May 2021, excessive salt in food and beverages is putting people at greater risk of potentially fatal heart diseases and strokes. CV diseases are the leading cause of deaths from non-communicable diseases worldwide, being responsible for 32% of all deaths. Out of estimated 11 million deaths each year associated with poor diet, 3 million are attributable to high sodium intake. So the WHO has taken an initiative. On 5th of May 2021, WHO took a bold and decisive move in this direction by releasing fresh guidelines for limiting sodium content in food items. The WHO has warned that the world is not currently on track to meet the global targets of 30% reduction in average intake of salt by 2025, goal set in 2013. And as per the Director General of WHO, the food and beverage industry should cut sodium levels in processed food. New WHO benchmarks for 64 food and drink categories were released. According to this, potato crisps should contain a maximum of 500 milligrams of sodium per 100 gram serving, pies and pastries up to 120 milligrams, and meats up to 360 milligrams. So that will be a very drastic cut in the amount of salt which is being put in these food items. And these are aimed at guiding health authorities of 194 member countries who are in talks with their food and beverage industry to regulate salt content in food items. So I think it's a very bold and a very encouraging decision, and this will definitely cut the incidence of coronary artery disease and other associated metabolic problems. So this study, this particular talk concluded that the evidence for a causal relationship between high salt intake, high BP, and CV mortality is very strong. It needs to be taken care of. And the totality of the evidence for salt is more robust than any other dietary variables considered to be important for CV disease. So this is something on which we all can work up, and normalization of salt intake from 9 to 12 gram per day to the recommended WHO level of less than 5 gram per day will have a major beneficial effect on CV health along with major cost savings. So this is something which is a modifiable risk, and it should be worked on aggressively. Unlike Western countries where up to 75% of the ingested salt is added in food during manufacturing process in India, sodium in diet comes from salt added during cooking. So we as Indians are in the habit of taking large amount of salt. We have got added examples like putting pickles, salads, papads, etc. So they all contribute to the higher intake of salt in our set of patients. The second important topic was hypertension in young age. We are seeing a lot of high blood pressure in younger age group patients. So there are obvious factors for that. That could be stress. And in this post-COVID times, you have seen a large surge in the diseases because of the stress associated with long sitting hours and the job-related issues and the uncertainties of the future. So the types of hypertension in the young could be essential hypertension that contributes to 80 to 95% of the cases, and secondary hypertension that contributes to around 5 to 20% of the cases. And these could be renal parenchymal hypertension drugs, obstructive sleep apnea syndrome, lifestyle, diet and nutrition, hypo or hyperthyroidism, renovascular hypertension, coarctation of aorta, Cushing's syndrome, aldosteronism, and pheochromocytoma. So, what could be the role of diet in essential hypertension? So, with the use of large number of preservatives and beverages, high intake of sodium and low potassium has a role in the pathogenesis of hypertension. A DASH diet, that is, a dietary approaches to stop hypertension, reduce salt intake, low fat diet, and increases in fruit and vegetables, lower systolic blood pressure in patients with pre-hypertension and stage 1 hypertension. So the DASH diet or the dietary approach to stop hypertension has a salutary role as regards to the prevention or in the management of essential hypertension. Vitamin D, low psychological stress related to vascular mechanism, which contributes to essential hypertension. Hyperuricemia may also have a causal role. So all these things were discussed in this very interesting talk. Then a schematic diagram was shared as regards to how do we suspect secondary hypertension. So a complete flow chart is there, and an algorithm approach is there. What all investigations should be put into place when we are suspecting secondary hypertension. Then secondary hypertension, prevalence and etiology of hypertension varies with age. Younger, early onset hypertension should be approached with the evaluation of symptoms. For example, flushing and sweating, symptoms of pheochromocytoma, examination findings, for example, a renal blood that could strongly suspect a renal artery stenosis or laboratory abnormalities like hypokalemia, which could lead to a diagnosis of aldosteronism. So the conclusions of this talk were, in young adults, particularly women, renal artery stenosis caused by fibromuscular dysplasia is one of the most common secondary etiologies contributing to hypertension. FMD can be detected by abdominal magnetic resonance imaging or computerized tomography. Essential hypertension is multifactorial, which involves interplay of genetic, SNS, RAS systems, diet, vitamin D3, psychological stress, and factors related to vascular mechanism, which contribute to essential hypertension. Secondary hypertension like renal artery stenosis, FMD, thyroid, hyperfunction, coarctation of aorta, TA, which are causes of secondary hypertension in young, which can be curable or controllable. But primarily, we have to understand that 80 to 95% of the contribution comes from essential hypertension. But in younger patients, these causes of secondary hypertension needs to be evaluated, and digital health solution, counseling services, mobile applications and gadgets which will monitor the diet, physical activity should be provided to young hypertensives. And I think they are more amenable to these type of newer advancements and newer methods of communication with the service providers. Then a very interesting topic on endocrine hypertension. So primary hyperparathyroidism, hypercalcemia is associated with increased frequency of hypertension and is the most common cause of increased calcium in primary hypertension. In hyperparathyroidism, the frequency of hypertension in patients with primary hyperparathyroidism varies from 10 to 60%. Then acromegaly was discussed. Hypertension occurs in 20 to 40% of the patients of acromegaly and is associated with sodium retention and extracellular volume expansion. The key takeaways of the talk were hormones play a significant role in control of blood pressure and also in patients with essential and renal parenchymal hypertension. Hormones play a significant role in hypertension associated with chronic inflammatory states, obesity, and chronic stress. Among the secondary causes of hypertension, endocrine causes account for second most important cause, preceded only by renal disease. So this is something which is to be taken care of and should be evaluated in every patient of hypertension. Primary hyperaldosteronism, pheochromocytoma, Cushing's syndrome are responsible for majority of endocrine causes of hypertension. Endocrine causes of hypertension may coexist with essential hypertension. So this also should be taken into account. Screening should be considered in patients who are young hypertensives, those with resistant hypertension, labile blood pressure, and sudden fluctuations of BP. So these pointers should make us think, and we should try to evaluate these patients for the endocrine abnormalities associated with hypertension. And most patients can be cured by appropriate surgical and or medical management, and early diagnosis and treatment is important. So having a very strong clinical suspicion, when we are having resistant hypertension in young people, labile blood pressure, and sudden fluctuations of BP. So these all should be pointers for evaluating for the endocrine causes of hypertension. Then a very interesting topic was discussed, that was antiplatelets and antithrombotics in peripheral vascular disease. And peripheral vascular disease, PAD, the frequent presentation of atherosclerosis with high morbidity and mortality. And I think this should be done at almost all of our centers. The evaluation for ABI, ankle brachial index, it is very easy, and it should be done in almost all patients, especially with risk factors like diabetes mellitus. It affects more than 200 million people worldwide. 4.2 to 6.2 million Indians suffer from severe form of PAD. PAD patients are at increased risk of major adverse cardiac events. Nth number of randomized controlled trials have shown this thing, be it myocardial infarction, ischemic stroke, or cardiovascular death. And asymptomatic PAD, which can be picked up by ABI measurements with no manifest coronary artery disease, cerebrovascular disease, do not initiate antithrombotic therapy. Manage CV disease risk factors. So modifiable risk factors should be addressed, be it smoking and other things. And reduction of weight, manifest coronary artery disease or cerebrovascular disease, aspirin or P2Y-I2 inhibitors as per current guidelines for stable coronary artery disease or cerebrovascular disease. Summarizing the talk, with no manifest coronary artery disease or CVD, clopidogrel or ticagrelor monotherapy to prevent MACE. Evidence suggests clopidogrel more effective than aspirin, and ticagrelor is alternative in poor clopidogrel metabolizers. With manifest CAD or cerebrovascular disease, aspirin or clopidogrel, if aspirin is contraindicated, to prevent MACE. And patients on aspirin and at higher risk of cardiac and ischemic limb event, consider adding ticagrelor if prior more than 20 months ago MI to prevent MACE and male. And lower dose rivaroxaban if patients had concomitant CAD to prevent MACE and MALE. For patients at high risk of ischemic limb event, consider adding vorapixar. Adding antithrombotic therapies to aspirin is associated with increased risk of major bleeding, necessitating consideration of the net clinical benefit of combination therapies. So we have to have a risk-benefit ratio has to be assessed every time, and it has to be discussed with the patient. The number of MACE and male events avoided relative to major bleeding events caused. The optimal antithrombotic therapy for patients with critical leg ischemia remains unclear and is currently under investigation for patients undergoing lower extremity revascularization. Then a very interesting topic, that is the exercise schedule in prevention of ASCVD. So updated risk stratification approach recommended by Lipid Association of India 2020 was discussed. So the risk factors, the major ASCVD risk factors were age more than 45 years in males and more than 55 years in females, family history of premature ASCVD, current cigarette smoking or tobacco use, high blood pressure, and low SDLC. So the other risk features could be diabetes with 0 to 1, other major ASCVD risk factors, and no evidence of target organ damage, CKD stage 3B or 4, familial hypercholesterolemia, extreme of a single risk factor, coronary calcium scores more than 300, non-stenotic carotid plaque, and lipoprotein A more than 50 milligram per DL. Moderate risk non-conventional risk factors were coronary calcium scores 100 to 299, increased carotid IMT, lipoprotein A 20 to 49 milligram per DL. So this is the moderate risk non-conventional risk factors. Then risk category groups, 0 to 1 major ASCVD risk factors and lifetime CVD risk less than 30%. 2 major ASCVD risk factors, lower risk group with more than 1 moderate risk non-conventional risk factors, So they have categorized, and extreme risk was category A, cat with more than one feature of high risk group, and category B was cat with more than one feature of very high risk group or recurrent ACS within 1 year despite LDL less than 50 milligram per DL or polyvascular disease. So the central illustration regarding the coronary atherosclerotic plaque regression was discussed. Then benefits of exercise were highlighted. The mood state, cardiovascular, and resistance exercise can positively affect different mood states, including tension, fatigue, anger, and vigor. So these two studies were quoted for this, and I think this is very well known that this works as a mood elevator. As regards to depression, cardiovascular, and resistance exercises are equally effective in producing antidepressive effects. Anxiety, even short bursts of 5 minutes of cardiovascular exercise stimulates anti-anxiety effects. Self-esteem, factors influencing a person's self-esteem are perceptions of their body attractiveness and physical condition. Current research provides little direction regarding the type of exercise and those recommendations for improved self-esteem, but definitely it has a positive effect as regards to self-esteem. The weekend warrior, a subpopulation of exercises, are those who do 1 or 2 bouts of exercise a week, perhaps because of no time or choice, found that weekend warrior exercises who had no major risk factors and expended at least 1000 kilocalories had a lower risk of dying as compared with their sedentary counterparts. However, individuals with one or more risk factors to CSD may not benefit from the sporadic approach to physical activity. So the gist of the talk was that it's always better to do something rather than doing nothing. So as per your conditions, as per the time allotted, you need to exercise because as regards to your CVD risk reduction, it has got positive benefits as regards to your mood, anxiety, self-esteem. So doing exercise has always a beneficial factor. It can promote in group exercise. It can promote social bonding and nth number of positive factors. And the other thing that was emphasized is that prolonged sitting should be avoided. There should always be movement after, say, movement breaks after every 30 minutes of regular sitting. Then a very interesting topic as regards to the statin intolerance. So this is something which is always should be addressed and should be this particular history should be evaluated with every patient who has been initiated on statins. And statins are we all know that they are gold standard for treatment of managing dyslipidemia, very especially in patients with diabetes more than 40 years of age. They are being used universally, and many patients take statins report muscle related symptoms. So are these symptoms are associated basically with statin intolerance, or they may be minor aches, and most important cause of statin discontinuation leads to increased risk of cardiovascular events. So as per the data from this interesting trial presented in European Heart Journal, the overall prevalence of statin intolerance was to the tune of around 9.1%, 7% National Lipid Association criteria, 6.7% International Lipid Expert Panel criteria, and 5.9% European Atherosclerosis Society criteria. So it's almost less than 10%. So how the LIE 2020 recommendations on statin associated muscle symptoms. So this particular thing was discussed. So if there is a bilateral muscle pain, proximal muscle involvement, onset within week to months after starting statins, then we have to take a history of concomitant drug therapy and comorbidities, assess biomarkers, serum creatine kinase, vitamin D3 levels, LFT, renal, and very importantly, thyroid function should be evaluated in every case who is being suspected of statin intolerance. And the assessment of muscular injury, tolerable symptoms, continue statins. If the creatine kinase is less than 4 times of the normal values, but intolerable symptoms, stop statins. If the creatine kinase is more than 4 and less than 10 of the normal levels and or intolerable symptoms, stop statins. And if creatine kinase is more than 10 times of the normal values without renal dysfunction, still you have to stop statins. DSS symptoms and creatine kinase every 2 weeks. Persistent symptoms or elevated creatine kinase for 6 weeks. look for alternate causes, a low dose, intermittent, a different statin, escalate every 2 weeks, achieve maximum tolerated dose of statin. So these are the modalities that can be used in these patients who are reporting statin intolerance. And then if the creatine kinase comes normal, symptom free after 2 weeks, then we can always look for these options like low dose, intermittent, alternate day, statin use, different statin, or escalate every 2 weeks. And if in extreme ASCVD risk, consider non-statin RX at 2 weeks. Non-statins like ezetimibe, BAS, fibrates, bempedoic acid, plant sterols, stanols, and PCSK9 inhibitors can be tried if we have got these contraindications because of the statin intolerance. And statins are generally safe and very efficacious agents for reducing the burden. Always, if the patient is reporting these type of symptoms, which are bilateral, proximal more, you should always evaluate the creatine kinase. Non-adherence and discontinuation occurs in patients with myalgia. So myalgia should, if the myalgia is persistent, then you should go for a creatine kinase. And if it is increased more than 4 times, and then you need to work up for statin intolerance. And negative press reporting about statin therapy is highly correlated with statin discontinuation. So if you go and you Google about statins, you will get these things, and then it could more be a psychological issue. And we definitely have to emphasize that statins are very important, and we have got studies to show that statins reduce the CV morbidity and mortality. And liver toxicity as regards to statin is rare. New onset diabetes occurs in high dose statin but can be managed. Non-statin drugs, including PCSK9 inhibitors, will play a major role, and we need more answers for many questions. But one answer we already have, that statins definitely prevent cardiovascular disease, mortality, and morbidity. Thank you.